Hello and welcome to another episode of Keeping London Healthy. I'm Dr. Mario Elia. We had such a great interview last week with Dr. Genevieve Eastabrook, and I had so many questions to ask her that she kindly decided and agreed to stick around for a few extra questions. So the first part of our episode today, we're going to be asking Dr. Eastabrook a few other questions that I had around the topic of pregnancy care. The second half of the episode, we're going to be dealing with some questions that I get in practice quite a bit and things I'm seeing day to day in my office and family practice. And hopefully you guys will find some of that advice helpful. So after this message, we'll be joined again by Dr. Eastabrook. Welcome back. For those of you who watched last month's episode, you'll recall we had Dr. Genevieve Eastabrook, obstetrician and gynecologist from LHSC, on to answer questions about pregnancy. So much useful information that I'm sure you guys got from that episode. And truthfully, I still had a number of questions that I really wanted to pick Dr. Eastabrook's brain about. So she was kind enough to come back this month to join us for an episode for a few more questions. So again, thanks for joining us again.
Oh, you're most welcome. It's good to be back.
One question I get all the time is in pregnancy, those patients who are getting some nausea and vomiting in pregnancy, which is fairly common. What can patients take, and what things should they be doing to maybe improve their nausea?
Yeah, so I mean, nausea is one of the most common symptoms in pregnancy that people have. And for some people, it can be mild, and for some people, it can be really quite debilitating. So the mainstay of treatment is actually a medication called diclectin, which is a combination of an antihistamine and actually vitamin B6 in a slow release tablet. And it's actually been tested for safety specifically for pregnancy and is kind of the mainstay of what we use. Now, it's not great for kind of like acute symptoms of nausea and vomiting. So if you're already feeling nauseated, it's not going to prevent you from vomiting. So it's something that has to be taken on a maintenance basis. But it can be taken throughout the pregnancy. I've had some patients that take it right from the beginning, right until right before they give birth, and other people stop it after the first trimester, depending on how symptoms are. If there are other medications that are needed, there's actually a whole kind of accelerating ladder of things that we can offer. One of the common medications that may be offered is just Gravol. And that can help with some of the acute symptoms. There's also some other medications. For instance, there's a motility agent called metoclopramide or Maxiran that some people need. And again, this is only available by a prescription and would obviously only be given under the guidance of a physician. And then there are some more substantial medications, things like Zofran or ondansetron for people who have really significant symptoms of nausea and vomiting. And if it's to that point, some people may even need to be admitted to hospital. They may need IV hydration. But there, before you get to that, there are also some really important lifestyle modifications in terms of things that can be triggering for nausea and vomiting, like fatigue, making sure that your stomach is never completely empty. So eating small snacks throughout the day, and avoiding kind of triggers for things. Some people also get lots of like heartburn and acid reflux, and that can contribute. And so treating that can sometimes be helpful as well. And then for people that are also having difficulty, with their prenatal vitamins, is we often recommend stopping the prenatal vitamin during the first trimester if it is contributing to nausea and vomiting, because it can certainly be a significant trigger, especially the iron.
So obviously vaccinations kind of in time of COVID have been kind of a hot button topic in terms of vaccinating pregnancy. What vaccinations should patients be making sure that they're up to date on before pregnancy, and then what vaccinations could they expect to be getting during the pregnancy?
We talked a little bit last time about testing for immunity to certain infections, and so for instance, people who've had a previous pregnancy and they find out that they're not immune to rubella, they should have an MMR booster prior to pregnancy because it's one of the vaccines that we don't recommend giving during pregnancy. In terms of pregnancy vaccines themselves, we actually have a routine booster that we give for whooping cough or pertussis, and that's given typically sometime between 26 and 32 weeks of pregnancy. And that's specifically to help to boost immunity for the baby, because babies don't get their first vaccines until they're 2 months old. So those babies are unprotected. So boosting mom helps to build antibodies that then cross the placenta that protect the baby in the newborn period. So that's a really important mainstay vaccine that is given. During the seasonal flu season, basically in the fall and winter, we also recommend that all pregnant people receive an influenza vaccine, regardless of where they are in the pregnancy, and that's typically from around sort of October through February, March, when those vaccines are available, and that's also a really important one because pregnant people can get very sick with influenza. They're more likely to land in the hospital with breathing difficulties. And it also helps to protect the baby against influenza for up to 6 months after birth.
One thing, over the past couple of years with COVID, there have been some horrendously inaccurate claims online as to the fact that COVID vaccinations are increasing stillbirths, increasing fertility rates, and I know people have kind of latched onto those online conspiracies. As someone who is working as an obstetrician and in the hospital and seeing pregnant women on a regular basis, what do you have to say about those kind of claims that are made online?
So this has been a big, I would say, passion of mine over the last 3 years, is to try to help to decrease fear and increase confidence in COVID vaccine in pregnancy. I think there's been a substantial amount of purposeful disinformation, unfortunately, just because COVID vaccines have become fairly politicized as well. And, yes, it is a new illness and, a relatively new technology. We know from tracking hundreds of thousands of pregnancies that have been recorded during COVID and people who have received the COVID vaccine, that there is no relationship between the COVID vaccine and miscarriage, infertility, fetal anomalies, stillbirth, anything like that. And in fact, having COVID during pregnancy, particularly in an unvaccinated person, and particularly during that Delta wave of COVID, was substantially associated with both maternal death and stillbirth, which was really unfortunate because there was a lack of confidence in the vaccine at that point, and so there were many people that were left very vulnerable.
Thanks for addressing that. As a family doc, we do our best to educate, but it's often helpful hearing it from, again, specialists in the hospital, seeing moms, seeing babies regularly, that again, COVID vaccination and influenza vaccination and all vaccinations that we give are quite safe. Let's change gears a little bit to some over-the-counter medications. So Tylenol in pregnancy, we get questions about quite frequently. Is Tylenol safe to take in pregnancy?
There was a review article that was written actually by, I think, a group or an endocrinologist, suggesting some theoretical concerns around the use of Tylenol in pregnancy. And then there have been some other sort of big data studies where, people can kind of spin things the way that they want using large volumes of data that potentially that Tylenol could be associated with things like autism and ADHD. So at the end of the day, though, when you actually look at that data, it's very, very limited in terms of the fact that it's a medication that almost every pregnant person actually uses at some point during pregnancy. And if there was a strong association with a lack of safety or problems, then everybody would have a problem, right? So and if you think about the biological plausibility of Tylenol causing these problems, it really doesn't make sense. And I think the most important thing, though, is that we're actually very limited in what choices of medications we can use safely for pain control in pregnancy and fever control in pregnancy. And, because for instance, we can't use medications like NSAIDs, so things like Advil, at particular windows of pregnancy, particularly in the third trimester. And so that limits us to things like opioid medications, which have their own issues and are stronger than most people would need for certain things. So Tylenol is kind of a mainstay. The other thing is that having a fever during pregnancy may be associated with later complications for baby, and early in pregnancy may be associated with an increased risk of miscarriage. And so treating a febrile illness like influenza or COVID is actually quite important. And I think there's been some editorials written by experts in pregnancy and in toxicology and in pain control, really saying that pregnant people deserve to have their pain controlled. I mean, it's a human right to be able to have your pain controlled. And so scaring people and removing these options is really a negative thing. So certainly if people need to take Tylenol, they should take Tylenol in pregnancy and not worry about it.
Patients will often ask about pelvic floor physiotherapy to kind of strengthen their pelvic floor. Any guidance for patients, either before, during, after pregnancy, for the benefits of it, or do they need to be doing this? Is it going to help them?
Again, in London, we actually are very fortunate because we have access to several pelvic physiotherapy clinics. And they do quite a lot of outreach as well. They've given talks at our academic half days and things like that about benefits. And I think one of the key things about pelvic floor and pelvic physiotherapy is it's not necessarily just about strengthening the pelvic floor, but it may be important as well for helping to relax the pelvic floor, to decrease pelvic pain, as well as this whole kind of strength concept. I think that everybody should have access to pelvic physiotherapy. In fact, in France, people who are postpartum all get 6 weeks of targeted pelvic physiotherapy, which is interesting and certainly not different, a lot different from here. Mm-hmm. But I think that there are benefits during the pregnancy for things like pelvic pain related to symphysis pubis separation, and SI joint pain, sciatica. There are people who have difficulties with pain with intercourse and pain with pelvic examinations. And so it's also important during pregnancy to help people become comfortable with examinations that may be needed, at the end of pregnancy or during labor. And then obviously afterwards for helping with things like pelvic floor prolapse, urinary stress incontinence, and that kind of thing. And so I think that there's many benefits, both during and after, not just strengthening the pelvic floor. The difficulty, of course, is that it's not funded by OHIP. So, if you are seeking pelvic physiotherapy, it may be covered by an extended benefits plan. And there are some clinics that actually provide some lower cost options as well for people who are on, plans like ODSP.
You mentioned labor. So we have one question about labor that we often get from patients around the topic of an epidural. Should they, shouldn't they, pros and cons? Any quick advice for them on that?
I think it's important for people to know that they have a full range of options for pain control during labor, and that can range from things like what we call hydrotherapy, which is like laboring in a shower or a tub, and then there's also other people use types of self-hypnosis and breathing techniques and whatnot. There's also the option of laughing gas, or what we call nitrous gas. And then there's something called a PCA, which is basically a pump with a button that you can give yourself short doses of a short acting opioid type medication. But I would say the majority of people giving birth in hospital will opt for an epidural, particularly for their first labor. And I think that it's important for people to know that, first of all, it's a very safe option. Second of all, it doesn't actually slow your labor down or increase the risk of cesarean section, but it can be very helpful for people, particularly with their first birth, when we know that labor may be long, and physically and emotionally difficult, and having adequate pain control is really important. So, it's a personal choice. But I also feel like people, should go in with an open mind about what kind of options they have, and not be necessarily scared or feel disappointed if they end up getting an epidural.
Well, again, thanks so much for all of your wisdom and advice. Again, Dr. Eastabrook. Again, thanks for coming back on this month's episode. I had far too many questions last month, so again, thanks again for coming back and for giving us all of those helpful tips.
You're welcome anytime.
And we'll take a quick break and be back right after this message. Welcome back. So for the second half of our show today, I've decided that we're going to do something a little bit different. I know in the past we've obviously brought guests on and specialists on, but one question I get asked quite often is, what kind of things am I seeing day to day in my office, and any advice that I have based on the things that we're seeing. So we're going to do this segment today, and we're probably going to do it every few months or so. Just with some common tips that I think everyone should really know about. So the first thing we'll talk about really briefly is around COVID vaccination. We get asked about this quite a bit: who should be getting boosted, who should not be. So just really quickly, guidance for anyone who is high risk. That's defined as anyone 65 or greater, anyone on immunosuppressant drugs, anyone who is in residential facility or institutionalized, should be getting their COVID vaccination every 6 months. So a lot of people got it back in the fall, generally advising those high risk groups to be getting their COVID vaccination now in the spring. And then the guidance will probably be for everybody, high or low risk, to be getting boosted in the fall around the same time as their influenza vaccination. I'm going to jump into something that we're seeing quite a bit here in the office. People often ask, are people getting sick, and what am I seeing day to day? You chat with a lot of doctors right now who see, kids and young adults and even older individuals, is just the number of people we're seeing with strep throat right now. It's honestly, I haven't seen this in many years. So things to keep in mind when you get a sore throat. How do doctors decide, is it a strep throat, which is a bacteria? Is it a viral sore throat? What are some things we look for? So there's four main things that we look for. One is a fever. Fever will steer us more a little bit towards it being a bacterial cause. Not always, but a little bit more towards it being a bacterial cause. Pus on the tonsils, more indicative of a bacterial cause than a viral cause. Absence of a cough. So if you've got a cough, likelihood of it being strep is lower. And the last thing is tender, large lymph nodes in the neck. So those are four things that we look for. Again, you don't have to have all four to have strep throat. You can have all four and not have strep throat, but it's just some things that guide us as doctors in deciding, is someone more likely or less likely to have a sore throat. Certainly, if you have none of those four, so if you have no fever, if you've got a bit of a cough, if you've no tender nodes and no pus on the tonsils, chances are it's viral. Can't say for sure. Always chat with your doc if there's ever any concern. But those are some guidelines we use. And again, we're seeing a lot of strep throat right now, especially in kids. Adults, seniors, far less likely to be strep throat. So certainly, if you're an adult and you have a lot of interaction with a child, certainly that will raise your risk of having strep throat. But generally, we're still seeing it mainly in children. The other thing we're seeing a lot of day to day in our practice is something called conjunctivitis, which you'll often hear referred to as pink eye. And we're seeing a lot of this right now. Why? There's a lot of viruses going around right now, and one of the symptoms in some people can be conjunctivitis, which will present as often a red eye, one or both, with some discharge, clear, goopy discharge. The reason I bring it up is that we're seeing a lot of it, and it's important for people to know that in the first 48 to 72 hours, someone having pink eye, the majority of the time, we'll actually just advise monitoring. And the reason for that is that the majority of conjunctivitis is viral and will be self-resolving. Now, certainly if someone's having issues with pain or vision changes or sensitivity to light or symptoms that are worsening over that first 72 hours, obviously important to get checked out, or if you have any other concerns, get checked out as well. But just to be kind of clear on our general approach, one of the reasons I bring it up is that I know that with pharmacies able to prescribe now, seeing a lot of patients who are going to their pharmacy with pink eye and getting drops within that first 72 hours. The pharmacist prescribing guidelines, I'll say, are a bit different than kind of the approach that most physicians would take. So just because the pharmacy is available and you can get drops quickly, please be aware that, again, majority of these are viral, and it is important to. I would generally recommend to be seeing your primary care provider if there's any questions about it, and not jumping right into drops just because you want something right away that's going to take effect. The majority of them are viral, and the majority of them will have to resolve on their own. Okay. A few other things we're seeing. So obviously summertime, people are out and about more. We're seeing a few different things. So one is ticks, common thing. Every spring we talk about it. Most kind of outdoor spaces where there is grass, bushes, longer foliage, make sure that you're checking yourself for ticks when you come inside. Ticks like to just stick onto you, and it is important to be doing tick checks on yourself, on your kids, when you come inside from outdoors. We just take it off. Generally advise use tweezers from the base of the tick and pull straight out. Don't just squeeze it with your fingers, because that will make it far more difficult to extract it completely. So use tweezers right up to the skin, pull from the tick straight up. If it's been on for less than 24 hours, it does not require antibiotics. You cannot get Lyme disease from a tick that's been on you for less than 24 hours. If it's on you for 24 hours, or you're not sure how long it was on you for, generally should be seeing your doctor at that point for a discussion around antibiotics. Animal bites or scratches. It's really important that if you get bitten by an animal, a dog, a cat, pick your favorite animal, you need to see your doctor right away. The reason is that risk of infection from any animal bite, even a little scratch of a tooth, needs to get seen right away, because the risk of infection from these is very, very high. Nothing worse than seeing when I see my patients a few days after and they haven't sought medical care and it's already a rip-roaring infection and they need IV antibiotics because it's too severe for oral antibiotics. So again, any animal bite really should be seen by a doctor ASAP for getting on antibiotics. Insect bites. Generally, my advice is that if putting aside if you're allergic to bees or hornets and you get stung by that, you have to take that general approach that you would take for an allergy. But for insect bites, I generally recommend that people consider taking an anti-inflammatory if they have no reason that they can't. So Advil or Aleve, icing the area, putting Afterbite on sometimes can help as well. And taking an oral antihistamine. So that's something like Claritin or Reactin or Arius or Allegra. Get the generics. They're much cheaper than the brand names that I just gave you. But taking one of those right away. And if despite doing all of that, the size of the bite continues to worsen, more red, more swollen, more painful, then should be seeing a doctor at that point, because most insects, whether it be a mosquito, a wasp, pick an insect that bites or stings, there is a risk of cellulitis, which is a risk of a bacterial infection. We see this a fair bit. So again, if you take those initial steps and things continue to worsen, definitely important to see your doctor at that point, because we may consider putting on antibiotics. If you're outdoors in the sun, even on a cloudy day, if you're outside, please be putting sunscreen on. And if you're outside for more than 2 hours, making sure you're reapplying that sunscreen, because we know after that 2-hour mark, the effectiveness starts to wane, and you need to be making sure that you're applying it every couple of hours. Now that we're outside, less bundled up, we're going to be seeing more of our skin. Making sure that we're checking our skin, especially seniors who've had a history of sun exposure in their life. Making sure you're checking your head, your neck for any lesions that are new. Especially in seniors, we see these lesions called actinic keratosis. They're really rough spots, kind of flesh-colored, rough to touch, often on their foreheads, some on their face. If they're missing some hair, they'll see it on the top of their scalp. If you've got these kind of lesions popping up, these sun damaged spots, please see your doctor for consideration to get these treated. The last thing we're going to talk about is exercise. The weather is better. We have no excuse not to be outside. So perhaps if we've been a little more kind of lethargic, a little more sloth-like over the winter, May is a great time of year to start making some plans for how we're going to get more active over the next 4 to 6 months. often for for some of us who need a little bit more motivation, putting pen to paper, establishing what your goals are, what is something that you enjoy doing, what can get us more active, whether that's indoors or outdoors. But setting a goal: how many times a week do we want to commit to? Is it once for half an hour a week? Is it more? What's a baseline level of activity that we can commit to? And again, even that's walking for half an hour a day, that is fantastic and a great use of the weather, and will decrease your risk of cardiovascular disease, will decrease your risk of cancer, make you feel less tired, make you feel, will help with depressive symptoms, help with anxiety symptoms. So obviously exercise is super, super important, and a great time of year to be kind of resetting things and getting us more active. For those of you who are interested, I do have a practice website where you can find resources for general health conditions, for mental health conditions. Patients often find it helpful, so you can check it out at drmarioelia.com. Again, the website is free to use, and some of the resources on there are either books or websites that you can check out. And until next time, stay healthy.